I come from a slightly different perspective, and I'm very grateful that Vivian invited me. My focus actually over the past 10 years has been on investigating what used to be called hysteria. And what I sort of want to, it's not working.
It's not on big.
Okay, so basically, I'm not implying in any way that what used to be called hysteria and long COVID are the same thing, although there are people who are implying that, and I want to be critical of that. But my approach is something different. I want to look at how current psychologization and contestation of long COVID and other contested disorders is linked through what I argue is basically a set of assumptions about implicit mind-body dualism that emerged from how hysteria was conceptualized and how these conceptualizations changed throughout the 20th century. And I argue that these mechanisms or these assumptions are basically applied to a set of contested multi-system diseases that some of which Vivian already mentioned, but some of which are also sort of broader because they're not necessarily all post-viral diseases. So CFS, of course, and Lyme disease and fibromyalgia, but also chronic pain, functional neurological disorders, all sorts of functional somatic symptom disorders. And very broadly, what a lot of these disorders have in common is that they're often referred to as medically unexplained, and they all have highly heterogeneous and highly fluctuating symptoms that are considered unspecific, and thus also have sometimes what is referred to as fuzzy boundaries. So clinically, they also get misdiagnosed as one or the other. They all lack an undisputed etiological explanation and or known pathophysiology. They typically lack standardized laboratory diagnostic tests and biomarkers, and they typically lack a reliable treatment. Often not just in medical context.
Why? It's not.
So not just in the medical context, but also in the broader public perception, they are often perceived as non-real diseases, and they have a huge number of alternative pejorative designations. So they're referred to as psychosomatic, all in your head, non-organic, psychogenic, sociogenic. And all these sort of designations are used interchangeably. And basically, I more or less argue that this designation as not real diseases is often implicitly or explicitly associated with hysteria, a disease which had been known or medically treated for several millennia, but which is widely thought to no longer exist. And you can find references to it in the medical discourse, but again, also in the broader public discourse. And this association of all these disorders with hysteria is kind of grounded in the fact that hysteria itself is the quintessential medically unexplained disorder. So if you look at this very long medical history, there have been always sort of different etiological explanations for a huge amount of heterogeneous symptoms. So hysteria is typically medically defined as a disorder that can mimic any other medical disorder. And from the first idea that it was like in the antiquity, that it was caused by the wandering womb and thus a female disorder, there were all sorts of systems that were then seen as causal in causing hysteria. And as a result of these changing theories, patients throughout history had been dismissed as simulators. Now, my main work is basically focused on how FND, so functional neurological disorders and somatic symptom disorders, are actually the current medical designations for the symptoms that were historically referred to as hysteria. And the important part for me is that nowadays FND is actually conceptualized as a genuine neurological disorder arising from functional disturbances of the brain. But in the clinical context, and also especially in the broader perception, FND is still seen as lacking any actual biological basis. So there has been quite a lot of linking of CFS and long COVID to either explicitly FND as a new form or sort of historical hysteria. And this has been rightly criticized by quite a few scholars as delegitimizing. And why even sort of comparing long COVID with FND? On the one hand, it's wrong because they are not the same disorders, but it's also been criticized as delegitimizing and as psychologizing, because FND, as I said, is still sort of perceived as not only not organic, not a real disorder, but as predominantly sociogenic or psychosomatic. And by comparing any other disorder to FND, what is then typically implied is that also the somatic symptoms of these disorders are basically just expressions of psychological distress and not manifestations of a real disorder. And what I want to sort of put into this room is that particularly insidious aspect of this psychologization is always this sort of related implication that's always sort of implied, and that is rooted in Freud's conceptualization of hysteria, that patients derive what is referred to as primary and secondary gains from their symptoms. And especially this secondary gain, which I will talk about, is problematic because nowadays it often sort of implicitly becomes equated with feigning. And unfortunately, I don't have much time to go into very complex history of hysteria, but some aspects of Freud's theorization are sort of important for my claim. First of all, although emotions have been related to hysteria before Freud, what was so specific about his theory is that he argued that emotionally charged memories of subjectively psychologically traumatic events, and this subjectively is important because he argued that these could be also sort of very trivial seeming effects, are converted into physical symptoms that then serve as symbols of repressed memories. So symptoms become symbols of psychological problems. And as I said, although sort of emotions and memories had been related to hysteria before, what was so specific about hysteria is that he really sort of dematerialized hysteria. He argued that hysteria had no physiological basis and that these sort of psychological factors that somehow convert into body are what causes the symptoms. And in the sort of framework of his further development of his theory of conversion, Freud then also posited sort of psychological factors that are implied in this conversion and that are responsible both for the outbreak of the illness, but also for its maintenance. And he referred to this as motive of illness or the intention to be ill. And he differentiated sort of two primary intentions or motives, which he called primary and secondary gain. So primary gain is sort of direct effect of conversion, an internal advantage that the patient gets by turning trauma or conflict into a symptom, because the conflict then sort of gets solved in a way, although the patient gets burdened with the symptom. But the secondary gain was what he claimed external advantage. So basically, by getting ill, a patient has the possibility to avoid responsibility that he or she doesn't like or attracts attention. And Freud's example when sort of developing this idea of secondary gain was of a young girl who learns how to sort of indice her parents' love by falling ill, and later in her marriage, where she's in a sort of subjugated position, falls ill, using her illness as a weapon to sort of fight against this subjugation. And according to Freud, although both gains are subconscious, they underpin and drive the conversion, and they result also in patients not wanting to get well. Now, this is a sort of rather complex story, which I will just go over very quickly. But what I argue is that in the course of the late 20th century, what happened is that initially Freud was dominant, and this sort of idea of hysteria as a purely mental disorder was accepted. So basically both diagnosis and treatment were focused on identifying psychological causes, but also primary and secondary gains, and then addressing them through psychoanalysis. But then, sort of beginning in the 1960s, approximately, with increasing biologization of psychiatry, there was first initial criticism of hysteria as not being a real disorder because it sort of is psychological. And then since the 1980s, there was also sort of increasing criticism of this idea of conversion, that psychological conflicts convert into physical symptoms. An increasing shift also in the clinical context to the body, sort of to diagnosing hysteria no longer through sort of focus on psychological causes, but through negative testing. So showing that patients don't actually have a physiological basis, which implicated basically the absence of any actual disease. And what also sort of made this secondary gain more problematic in the course of the second half of the 20th century is that in the clinical context, the focus also sort of shifted to differentiating real patients with actual somatic symptoms of hysteria from feigning. And on the one hand, there were sort of two different categories that were introduced. Malingering as a sort of conscious intention to simulate symptoms, and fictitious disorder as unconscious intention to adopt sick roles. And that made this boundary between secondary gain as this subconscious avoidance of unpleasant things and simulation increasingly porous, and not just difficult, but actually almost impossible to establish in practice. And what I argue is basically that especially the secondary gain led to increasing patient blaming. So on the one hand, there was this disorder with seemingly unexplained symptoms that apparently lacked any physiological basis, where sort of psychological causation through this non-acceptance of conversion also became increasingly problematic, but internal and external benefits were still sort of a primary aspect of the disorder. And especially the secondary gain became problematic because it was no longer part of this illness mechanism that Freud suggested, but suddenly became something that was seen as illegitimate and in some cases also really explicitly coded as morally reprehensible adoption of sick roles. And in the DSM-4, you actually see these explicit descriptions of patients as having complaints in colorful and exaggerated terms in order to attract attention. And you have quite a lot of literature on patients being described as difficult, impulsive, over-emotional, histrionic, suggestible, dependent, manipulative, help-seeking, resisting their diagnosis because of lack of biological findings. And also, this is a sort of classical consequence of secondary gain, avoiding treatment and not wanting to give up their symptoms. And basically, this is what I want to finish with, that despite this current reconceptualization of this current diagnostic labels for what used to be hysterical symptoms and this idea that it's actually a genuine disease arising from a brain dysfunction, this still sort of culturally very present idea of hysteria as a psychosomatic ailment that doesn't have a biological basis and that serves patient to gain both internal and external benefits is very virulent in clinical context, but also in the public perception. And that especially these things are then transferred to all the other disorders that are currently viewed as medically unexplained and lack sort of these very clearly established pathophysiology. Thank you.